Hi, I'm Dr. Sara Fossum, a board-certified dermatologist with the University of Michigan. Today, I'm going to discuss recognition and management of hidradenitis suppurativa, or HS for short, for the practicing gynecologist. This education is brought to you by the HS Foundation. Part of the foundation's mission is to help educate all providers about proper diagnosis and treatment of HS. During this lecture, I'll discuss three specific topics related to hidradenitis suppurativa. One, recognition of HS. Two, which methods of birth control can help treat HS. And three, when to defer to dermatology. So to start off, HS is defined by three things: characteristic lesions, predilection for flexural sites, and lesion recurrence. The characteristic lesions of HS are deep-seated nodules and abscesses, skin tunnels, and scars. Early lesions can heal with double-headed comedones, which can aid in diagnosis. The flexural sites that are commonly affected are the axillary, groin, perianal, perineal, genital, and inframammary skin. And again, the third characteristic is lesion recurrence, or more than one flare in a 6-month period. Lesions can recur in the same site or in different sites. HS should be differentiated from folliculitis, which consists of superficial pustules based around a hair follicle. Folliculitis does not typically leave scarring, but it may leave post-inflammatory hyperpigmentation. HS should also be differentiated from cysts, which may be multiple, but are typically well demarcated. You can oftentimes feel the surrounding capsule or see a punctum. Also on the differential diagnosis is a furuncle, which has superficial pus, always grows bacteria, typically Staph aureus, and is typically not recurrent. Move on to the second part of this video. Certain birth control methods, specifically oral contraceptive pills or OCPs, can be part of management for HS. OCPs have been shown to decrease the number of inflammatory nodules and abscesses in a cohort study of HS patient. This effect was more significant in patients whose disease worsens with their menstrual cycle. The OCP with the best evidence in HS is drospirenone ethinyl estradiol. You can also consider the drospirenone-only pill in patients in which estrogen is contraindicated. Other considerations include other OCPs that are approved for the treatment of acne, including norethindrone ethinyl estradiol and norgestimate ethinyl estradiol, and the third-generation progesterone desogestrel. Although there is a relative paucity of evidence in HS, there is a risk that other birth control methods may worsen disease. The final thing I'll talk about is when to refer to dermatology. Patients with skin tunnels, extensive disease, or significant scarring should be referred to dermatology as soon as possible. In patients with mild disease, if you or their primary care provider feel comfortable managing, you can start treatment. But if their disease is not responding to first-line treatment or you're unsure which treatment to start, that would be a great time to refer to dermatology. Getting these patients adequate treatment is so important to prevent worsening disease and improving their quality of life by decreasing pain and drainage and flares. Thank you so much for taking the time to watch this video.